now we see Dr. Ramesh Daggupati sir, who is logged in. Actually, he is supposed to come and do a case along with Sai. But again, thank you, Sai. We are able to see you and unmute the Chennai center. We're able to see you, and Dr. Ramesh is not with you there, but he's on this side.
I miss him already.
Yeah. We also have Dr. Saurabh, Dr. Duane here, and we apologize once again for slight delay because.
No, I thoroughly enjoyed listening to Dr. Tang. I was happy to have waited.
Okay.
My patient's under GA. He's not going anywhere. Hi, everyone.
Okay. The other panelists are also here, and Amit and Sharath, Manik are all waiting to see your case. Over to Ramesh.
Hey, Ramesh.
Thank you very much, Dr. Srinivas Kumar, and great pleasure to be part of TCT India South Asia 2021. And unfortunately, I'm not there in person, but obviously always all my best wishes for all the speakers. Dr. Tang's lecture was fantastic. And all the live operators, we have seen some of them in live on Live Case in Box and Arena 1 and 2. Without further ado, I thank all the panelists who are there, Amit and Saurabh, and I'm going to hand over to Dr.SaiSathish, whom I had the pleasure to work with. Is an excellent gentleman, has a lot of experience in Mitra clip in India, able to perform several procedures on his own actually in very critical patient states such as in cardiogenic shock. And handing over to you now, Sai.
Sai, let me express and confess in front of everybody that he took some extra efforts to keep Chennai open for us in spite of tough COVID times. He went up to the health minister, regular government levels, and brought permissions. Thank you, Sai, for all your efforts. Over to you.
It was my pleasure, Srini. You're embarrassing me. If not for the mask, you'll see me blush. First of all, thank you, Sushil, Srini, all the organizers of TCT India, Asia Pacific for having us here with you. And even though Ramesh is an Atlantic Ocean away, I really miss him being here. Can't wait to host all of you here in person, but for now, this will have to do. Before I begin, I'll quickly introduce the team. To my right is Dr. YVC Reddy. He's been with me through most of my structural cases, a pillar of support. Dr. Vijay Kumar is here. He's from MMM. He's actually here as a spotter today. One, he helped Vinod load the clip up. And two, because this patient is so sick, I just wanted an extra pair of eyes around. So that's Vijay. Vinod is our TDS from Abbott. And Professor Chandrasekhar, his contribution to the cases that I've done have always been invaluable. He's from Mayo Clinic. He's here today with us, supporting us with the echocardiogram. This introduction won't be complete without Ganapati, who's been our cardiac anesthetist for all the procedures we have done. When he's at the head of the patient, I forget about the patient. I just do what I do. Sister Karunya and Mail, who is my technician for years and years. With this, I thought I'll briefly introduce the case and then jump into what we have. It was very sweet of Ramesh to say that I've had some horrendous cases performed in the last couple of months. Unfortunately, necessity is the mother of all invention and learning. This COVID has only brought the worst of the worst cases to us. And we were very lucky and fortunate to have gotten all of them out home to their families. This patient is no different from all the others we have treated so far. He's a 41-year-old farmer, no comorbidities, healthy until early this year. He started with the first episode of pulmonary edema at about 7:30. He was taken to a local hospital in Vijayawada. Ramesh, your neck of the woods. He was taken to a local hospital in Vijayawada where he was treated for heart failure and he was sent home. No echo was done. He progressively became sicker, ended up with first PND episodes, then went on to orthopnea, ended up with frank pulmonary edema episodes, and then was rushed to Hyderabad. He spent almost a month and a half in Hyderabad, unable to be weaned off supports. He needed dobutamine. He was in refractory heart failure, and he was put on a transplant list, and his lactate was climbing. When they no longer could hold him, the family shifted him to our care about 2 days ago. And I was brazen enough because of all of you and because Ramesh is on the panel, so I knew I'd have enough support from Professor Chandra and everybody to actually show this case. While I was actually waiting for you to begin, but while Professor Tang was talking, I thought, why not just save some time and take a quick septal puncture, get the guide in, and so that I can start straight away. So quickly to go over the steps, I do a standard puncture with a needle on the femoral vein. It's usually blind if it's the vein. put an 8 French sheath in just to dilate the channel, put a perclose in, pin the perclose on the side, take it out, go in with the septal puncture needle, and Professor Chandra will show you the septal puncture. It was a challenging puncture because the LA was large, the septum was ballooning towards a small right atrium. There were plenty of ectopics, which I'm sure you can see the monitor. Are you seeing the monitor? Can we go to the monitor and the echo? That's perfect. So you can look at the echo images, you can look at the monitor, and you can see there were multiple ectopics. It was a challenging puncture. I went a little posterior, but in this case, I wanted to finish as quickly as possible, so height was more important for me. So I took the posterior inferior stick. Professor Chandra, would you like to say a few words while I start moving the clip in?
Yeah, I think if you look at it here, the fossa ovalis membrane is right here, and it is at the superior aspect and posterior aspect of the fossa ovalis membrane, also quite inferior if you look at it. And then if you turn it around, this shows you the height nicely from here to the mitral annulus. So I'll freeze this picture and I'll show it to you. See, sometimes 2D echo can show biplane and other things, but 3D with the advantage of depth, we're able to get what we need to get. Here is 4.4 is the height of the mitral, the puncture site to the mitral annulus, and it also shows you how far away it is from the aortic root. So, and also it is just.
Sorry to interrupt, Dr. Chandra, sir. We can't see your video.
Oh, yeah, okay.
Or the echo screen. We are only able to see Sai and hemodynamics and the flow.
Can somebody get the echo on? Can somebody get the echo?
Can you come here?
No.
Yeah.
Just seeing it here.
Yeah, we can see the 3D echo, but what you're pointing, we are not able to see.
Oh, that's okay.
He's talking 3D echo only.
Yeah, that's right.
So the key is keyed in?
I mean, can you see the arrow now?
Yeah, I'm happy.
Yes.
Yeah, the same arrow is the one which I'm pointing out where. So this is the guide that has come in to the left atrium, and this is the aortic root, left ventricle, left atrium, mitral valve, anterior mitral leaflet, aortomitral curtain. This is the right atrium. So in this case, what we did was, basically here I'm going to go to the 2D. So here I'll point out, if you look at it here, so I'm going to go live with the explain. So look at how the guide has gone now. So here very nicely IVC, this is your liver, lower end of the interatrial septum, and this is the fossa ovalis membrane, and well into the lower end of the posteriorly as well as superiorly enough height and retroaortic. So you can hear, I'm just scanning back and forth so that you can get a feel. So this, even though it is little bit difficult since the RA was small and LA was big and the LV was about 8 centimeters, so the whole heart is rotated. When the whole heart is rotated, the normal right atrium and the left atrium doesn't have the same anatomic relationship. And when you look at the fluoro, you're not going to be in the same spot where you think in a normal heart. So I think there, even with the biplane imaging, it was a little bit difficult. And the 3D definitely plays a bigger role here. If you can see it here, one live image, you can clearly see the location of the catheter and how that comes into the atrium, which I'm going to show you right now.
Okay, Chandra sir?
Yep.
Sure, the clip is in the LA. Shall we move it forward?
Very good, okay.
Okay, Ramesh?
Yes.
You can
think
see
the most important point here is that the stick that you did is fantastic. You got a 4.4 centimeter height from the mitral annulus, and great help from both Dr. Ganapathy and Dr. Chandra for supporting anesthesia and the TEE. This is a procedure which cannot be done without TEE. So please go ahead, Sai.
Absolutely. So Ramesh, you can see where my guide is. You can see that I'm just coming out. Professor Chandra, short axis of base, so I can see the lateral wall. And could you just focus on the clip so I know I have enough space? And I'm clear. Can I keep going?
Yeah, please.
Okay.
Plenty of room in the left atrium.
Yeah.
And you can see the small bubbles and that from the guide, but a lot of room that you can advance it, I think.
Yeah. I'm just going forward slowly.
Yeah.
I mean, the left atrium is so huge here that that gives more latitude to advance the clip.
There you go.
Absolutely.
So as you can see, we have done the straddle.
Yep.
Yep.
Okay. So
So for, I think, people who are in the audience, straddle is where in the floor row, you can see the 3 radiopaque markers. One is in the center is the guide, and on either side of the big radiopaque marker are small radiopaque markers, which are the catheter delivery system. That is called straddle. Yeah.
so I don't know if we discussed the anatomy of this, I mean the pathology of this MR. It's a bit of flail and a bit of functional. There is a P2 flail, which we will show you shortly, which is nicely prolapsing. And if you look at the 4-chamber view, you will actually see that there is tenting of the commissures inward, which is typical of FMR as well. So the LV is large, which you would have guessed, about 8 centimeters. You can look at the flail segments there very clearly. Here you can see the FMR, the tenting, and you can see the flail segment popping up. Ramesh, you agree?
Yeah,
Okay.
I agree. This is a mixed picture. Definitely, there is. You can look at the size of the left ventricle is large, so there is definitely dilated LV. There's some coaptation issues, but the leafleter there is also a small prolapse segment.
Okay.
In that.
And here you can see the little prolapse chordae jumping out in the PML. You can see this anesthetist view just for the audience. You can look at the aorta on top. You can look at the anterior mitral leaflet above, the PML below, with the prolapsing chordae. Chandra sir, can we have the tip of the clip, because I want to bend down and let's
Sure.
get this done. Can I see the tip of the clip, please?
Yeah, I will. I'll bring it in.
Ramesh, what time is it for you?
Now it's 11:40 for us here.
Mid-work day, yeah?
Yeah.
Sai, don't worry about the time, because we delayed you. You can do it coolly, and we're with you till you finish the case.
I'm very cool, Srini. No
Yeah, there you
worries.
go.
So, but thank you. So you can see I'm nice and clear from the superior pulmonary vein. I'm clear of the Coumadin ridge. And if the panel agrees, I'm going to start giving the M and bending downward.
Yes, please.
It looks good, Sai.
Perfect. Thank you, Amit. I recognize your voice right away.
That's Saurabh.
Hey, Saurabh. Hi. Hello. Sorry.
How are you?
I'm good. I'm good. It's just so bad that all of you are so far away.
Yeah, I know. We'd love to be there in person.
So I think I just need to go posterior with the guide. I think I'm very anterior. Chandra sir, can I see a proper view? Bicommissural.
Oh, you hold on. Bicommissural. Let me get you the bicommissural view.
Perfect. So just quickly adjusting the straddle, moving the clip arm back, the sleeve. Every time you make movements and there are bends, the sleeve tends to come off the tip of the clip, so I just moved it back. I'm hoping I'm not seeing the clip, so I'm a little concerned.
You
You
need
can
to.
put more M, I think.
Yeah.
Yeah, but I don't want to move it, Ramesh, without seeing the tip of the clip. Chandra sir, can you find the tip of the clip? I want to see it before I move it. I'm free of everything, right?
Now you need to pull back a little bit.
Your anterior.
Yeah.
So go posterior.
Yeah,
Yeah.
that's what I'm doing.
Pull back a little bit and go posterior.
Right. Yeah.
Very good.
I'm better now. There.
Yeah.
Yes. Yeah.
Much better, guys.
I think
Posterior.
you're clear of the.
Coumadin ridge
Yeah.
for sure.
Everything is fine. Yeah.
I need to see my Chandra sir clip. Yeah. Yeah. So some more M, Ramesh.
Yes.
Yes, please. Yeah, I agree with that.
So I'm going some more M. That's looking good. I'm just going to pull the sleeve back. There you go.
And real bicom now.
Chandra sir, can I have proper bicom so I can look at
It
my...
is right now.
Okay, perfect.
Yeah.
Okay, so, just from this view in AP, when you look at the fluoro, I know that my 3D NFOS is not going to be right because I don't want the clip facing me like this. I want it as a single line. So I'm going to turn it a little, and then I'm going to check for perpendicularity. Agree?
Sai, do you want to show us a trajectory? Okay, there you.
There I am. You read my mind, my friend.
Yeah, it's such a big left atrium, and I think you're biased a little bit anteriorly just
Yeah.
on how that clip is going, so that may be a tad problematic.
So
The trajectory looks good.
The
You can put
trajectory-
a little bit more M, I think.
that's what I'm doing. I'm going to put a little bit more M. Yeah.
Hold it there for a minute, Sai. Yes, hold on.
I've
Yeah,
gone
yeah.
Samo M. How does it look?
You're in the right area, right perfect area. I think you're perfect actually.
Just moving the stabilizer a little more forward. 1 minute, Chandra. I just want to get over the jet. 1 minute. There you
Yeah.
go. How does that look, guys?
Looks great.
Yeah, I like it too.
You
Look at my trajectory.
Yeah, that's fine. That's pretty good.
Vinod, what do you think? Look, you like the trajectory? I'm right over the flail. Okay, so I think I'm in a good place. Any comments from the panel? Sarab, Ramesh, any suggestions?
No, it looks good. I think time to check clip orientation.
Perfect.
Yep.
Professor Chandra, you'd like me to come a little more anterior?
Yes, little.
Little
Just
anterior.
a little.
So if
Yeah.
you want me to come anterior, you want me to go to LVOT or just wing it from here?
No, I can go to LVT. I can show you LVT.
Perfect. I can see that on the right side. I can see the explain. Perfect. Are you okay now?
Looks good. I think very good.
I think it looks very good. Trajectory is good. There's no tension on the system. Maybe I should start opening the clip arms. What do you say?
Yes.
Yes.
Okay. Professor Chandra, can you just
Yeah.
quickly check with color if I'm in the right place?
Yep.
Yeah, right in the middle.
You guys are okay?
Mm-hmm.
Okay.
Yeah.
Perfect. No? I'm splitting the piece up perfectly in the right side.
Right.
Okay. I know I'm not supposed to say these things, you guys are, but I couldn't help myself.
We agree with you.
Okay, so let's open the clip. Half turn close. First raise the gripper. Just 1 second, let me just step over here. The light is in my eye, guys.
Ramesh, for this clip to get deployed, I feel the technology is a little complicated stuff and it has to become a little more user-friendly. And I don't know, because finally if you see it's a small clip which costs so much and this technology of releasing it and all is quite challenging, unlike TAVI. But I think we are evolving with time and the length of the clips have increased now to
Perfect, I like it, Vinod. Thank you.
longer ones. I think we are able to treat MRs better.
Chandra, you're
but I
okay?
think there's
Yeah.
Okay.
Yes.
I'm just opening 60 degrees, I think. So this is an XTR. I think just for the public, we can say that we did 3 clips recently, so we've run out of stock. So I have just 1 XTR and 1 NTR. So I hope we're going to wrap this up in that. This clip is slightly bigger than the NTR. I think that is 18 millimeters close. This is 20 with the arms open. That's 20 and this 25, if I'm not wrong. Please correct me, Vinod. Okay. So
I gets what is most latest. I was thinking XTR is not yet there, only NTR is there in our country.
it's all there, it's all there. Okay. So do you guys, this is enough, open enough?
Yeah, you can
Can I
open
have-
a little bit more.
Can I have 3D NFOS now? So
Yeah,
I can check my perpendicularity with the plane of coaptation? I'm just saying what I'm thinking for the benefit of the audience and for the benefit of my esteemed panel tweaking me.
So yeah, you can see on fluoro as well. When
It's
you
not
see
the right
clip
angle,
arms like
yeah.
that on fluoro,
Yep,
you're going to be parallel to the annular plane. in ATP.
absolutely,
You need to rotate clockwise.
absolutely. So I'm going to rotate clockwise, okay?
Yeah.
Small rotations with forward torque. Here we go. So what we want to do is, if Ramesh will explain what I ideally
Yeah,
want to
so-
do, hold the guide stabilizer, Vinod, Vijay, thank you. I don't want this to move. We'll just
So what
tighten this.
the clip arms have to be actually perpendicular to the annular plane, so as to be.
So
able
it's
to
gliding
pass
very
the
posterior, so I'm just moving it a little anterior. Yeah, you see that? That's better.
Good job, excellent.
Little bit more.
A little bit more. I've reached the limit of my knob. Somebody remind me that I'm turning upside down, please, in case I forget and I mess up the clip and the grippers.
Little bit more rotation. And also a little bit more anterior. We have to come.
Yeah, I'm doing
Lateral.
Yeah, lateral. Probably you can push the whole system later, but
that. I like it. I like the way it's looking now, actually.
Yeah, no, the perpendicularity is fine, but you got to
No, but the problem is the torque had to be transmitted, so I just have to wiggle it a little.
Very
There.
good.
I like that. What do you say?
Little lateral, let's
So you want me to move everything back a little?
Yeah, everything for push it forward.
forward,
Just a
forward
minute there.
to go
It's
lateral
very
on the.
medial now. I think I'm going a little.
Yeah, that's fine. That's fine. Right now,
Looks good.
right now it looks good. We'll
Is it too
verify.
anterior? Should I come a little posterior? Just a
I
tad?
think what I've noticed is that in this 3D on FOSS view, you can sometimes be fooled by
Yeah.
how anterior or posterior.
So let's go
you are
to
depending on
LVOT.
the tilt of the probe. Yeah, so that's a much better plane to adjust this in.
Okay. I'm up for grabs.
Yeah.
Okay. How do you like this? All looking good?
Yeah, in the LVOT you can see.
There's
Yeah.
the LVOT.
So
I
the-
can see my clip
You
arms.
have to come anterior, a little bit more lateral
You want me to go more inside?
inside and
More
also
I think
lateral.
1 minute. I'm going a little
Yeah.
posterior first. There you go. Okay, Ramesh, you like?
Yeah, you're doing a good job, and I think it's doing well.
Okay, so do you want me to
And,
cross now? There you go. I think a little more posterior, Ramesh. I'm touching the anterior leaflet.
Yep.
There you go.
Yes, you could go a little bit right. That's
Okay.
good.
I think that's good.
Maybe. So the perpendicularity is good. You saw your trajectory. That was
I like
good.
it. I'm going to go under, guys. I'm happy.
Yes, please.
Are you all happy?
Yeah, we're all happy.
Okay,
If
I'm
you're
just-
happy, we're happy, Sai.
Ganapati,
Vinod,
everything
I'm sure,
okay?
is happy in the back.
Okay, so I'm going down.
Vinod has the most experience in India with all the clips in from multiple centers.
Okay, so I'm down. My arms look okay. Maybe a little more anterior. Little more anterior
Very
to grab
good,
that.
very
There
good.
you go.
Yeah, so posterior is already falling on.
Yeah.
And
I think I should open the clip arms a little more and get ready for pulling up.
right.
Open is this way, right, Vinod? I've turned it, so let me just see. 120 is
Ganapati,
okay?
Magnesium.
That's good. Yeah.
Okay.
Sai, just wait for a second. The PVCs.
Yeah, there are too many PVCs. I don't want anything yanked out. I'm just going to wait for him to give some magnesium. Like I told you, this guy's been miserably ill, on dobutamine, on milrinone, barely holding on. I'm actually hopeful that while this might be a bridge, I'm actually hopeful that he'll do well enough to come off the transplant list.
Yeah. Give some Lido actually if you want the
Yeah, I don't need
PVCs to
it.
be stopped, and the pull back as well. So that maybe it's not too deep.
Hey,
He-
so
he
do you want me
just-
to
he
quickly
just
see
gave
3D and
lidocaine,
FOSS to make
Ramesh.
sure I'm okay? Oh, this is fine.
So you have to go in. Your posterior is not.
Yeah, yeah. But do you want to
Not
see?
well.
Okay, I'm going to go.
In.
Can I just see the orientation, Ramesh, once by 3D and FOSS?
Also,
Yeah, so orientation and then a color jet, right?
Yeah,
in
yeah,
the
both.
bicolor
Because
to
I
make
because
sure.
yeah, that's because I moved down. I don't want any talk transmitted. Professor Chandra, may I see 3D and FOSS?
I'll show you. Yeah, here's the color. It's splitting it nicely.
Yeah.
So beautiful. I'm bang in the middle.
Just hold on.
All I have to check is orientation.
The most important person in this whole is Dr. Chandra.
He's given Xylocard, so you can see now the rhythm is stable. It's short acting. So my anesthetist wants me to hurry. Professor Chandra,
Here.
let's
here,
make the grasp and then
Here is the.
3D and FOSS. A little counterclockwise, huh?
Yeah, no, hold on. I'll
Okay.
take the.
Let's look at go to the depth of the arms.
Yeah,
and
yeah.
So
Yeah.
you were at 11.5. I probably
More little
do
clockwise,
a
huh?
little bit 12.5,
Yeah.
12.6.
Yeah, little clockwise, I think.
There you go. It's fine, fine. Just leave it there.
Okay.
Look at that. So you take away the gain, you see the clip nicely.
Okay, perfect.
Yeah.
Okay, let's go back to LVOT, sir. Let's
Yeah.
finish the grab. Saurabh, Ramesh, all happy?
Yeah.
Yeah, we
happy.
like it.
Okay, so I'm moving back up a little. My posterior's in, anterior's off. I'm going to glide a little anterior. Pull up.
Great.
Both are off.
Posterior is gone. Okay. There you go.
I'd suggest closing the clip down just a hair, Sai.
Yeah,
I
so
think
that
it'll make the posterior leaflet
Yeah.
fall in a little nicer.
little bit, just a tad. Yeah, there you go.
Yeah.
So my posterior is nice and in, but my anterior is bouncing all over the place. I am coming anterior. I'm going down a little. I'm coming
Posterior.
anterior.
Yeah. Go,
Posterior is out now.
I need to see my clip arms nicely, Chandra sir. Ah, there you go. Anterior's in now.
Are the clip arms now 120 or is it closed?
I'm just
more
open.
than
It's closed a little more, Ramesh.
Yeah,
Yeah,
now Sai,
Yeah, now it's good. So anterior is in, was in. Okay. Get the anterior and then rotate more posterior.
That's what I'm doing.
Anterior is in. So now go on the guide to the posterior.
A tad posterior.
Okay.
Now posterior's in, my anterior's off.
I think,
I'm going to go back down, guys.
yeah.
Come on.
Yeah, I think so. Anterior is in. Just don't do anything now. Pull back and drop the grippers.
I wish it was that easy. It's bouncing off.
No, I think your anterior is in.
Anterior's in, Ramesh, but
Yeah.
posterior's off.
Yeah,
See?
just a little posterior. So timing also obviously is everything in these patients.
Shall I go down on the breathing?
and now Sai, now Sai,
Both
now
are in.
both are in. Sai, drop the.
Oh,
No.
the ectopic. Just kicked it out.
Yeah, you can hold the vent as long as.
I think both are in. It's
Yeah, both are in.
posterior's off.
I think both are inside actually. Drop it off.
Both are off.
Okay. Drop the no. You both are in. You're seeing it and
Yeah.
drop the grippers and see first.
Let me drop the grippers.
Yeah.
Yeah.
Posterior's off, Ramesh. See?
Yeah.
Huh? No, I didn't lock it.
Posterior is off.
The grippers are dropped. My posterior's off.
Yeah.
Close it and see. And
No, it's off, Ramesh. I can
No,
see it very clearly.
posterior is
Posterior is off,
completely
yeah.
off.
Yeah.
Yeah. So I'm going to take the grippers. I'm just going to.
you can make the echo much bigger screen if you want to.
Okay.
Yeah.
For the live audience.
Okay, hang on one sec, guys. Just one sec. Professor Chandra,
Yeah.
can I just go to 3D and FOS?
Yeah.
Ganapati, go back on the breathing. Let's just start from the beginning. Let's check the orientation and let's just go for this. It's the ectopics and everything making it difficult. It's looking good now.
Yeah. Sai, posterior is lying there. You try to.
YVC, will you be ready to drop the gripper because I'm doing the posterior anterior. The gripper is this one. Okay, when I just tell you, just get ready to drop it. Okay, hang on, fluoro live.
As you're withdrawing, he should drop it.
Hang on one sec. Hang on one sec. My anterior's on.
Go a little bit posterior now, just.
Both are off. Okay, let's go to 3D and FOS.
Yeah, not a bad idea to make sure that,
Breathing back on. We're only 20 minutes in. We have time. I hope you guys don't mind.
No, this can be tricky, especially in a patient like this.
I just want to make sure my 3D and FOS is correct. And remove the gain.
I think a little bit more rotation. Sai.
Clockwise, huh?
Clockwise, little. Yeah, but it's okay, the same.
I'm fully inverted on the clip.
Yeah, it's okay.
Okay?
Yeah. The same.
Is that okay?
Yeah,
Okay. Can we go back to LVOT?
okay.
Posterior's in. YVC, get ready to drop the gripper when I tell you. I'm just going to sail towards the anterior.
Now,
Drop
now
the grip. 1 minute. I'll tell you when I tell you. I'm just moving anterior. Just wait, YVC. 1 second. Posterior is still in, so I'm sailing a little anterior.
As is working, Ramesh, what is the regular procedure? You clip both together or you clip one and you catch all of AML first and then go to PML? Actually, ideally, both should be once.
Right. Yeah. Even though we using now G4, the fourth generation clip, and where you can do individual leaflet grasp, we still
Anterior's in.
mostly grasp both of them at the same time. And so there is
So it's a
the
clip.
current generation in India is only that you have to grasp both of them at the same time.
Guys, what do you think? Anterior's in?
Anterior is in, I think.
Okay, I'm just going to go back down, nice and comfortable.
So it's the same for us, Srinivas, with the newer G4 version. But I like to grasp both at the same time and then use the individual grippers to optimize it rather than capture it that way. I think I've only done one leaflet
Ganapati
capture
breathing
once
off.
where it was really hard to grasp.
Anterior is in.
So can you go back to my clip arms?
Yeah, that's what I'm doing.
This is distracting me.
Yeah.
Every time I go down and up, my clip seems to be rotating here. Chandra sir, can I see my clip arms properly?
Hold on, Sai, for a second. Just give me a second. I think let me position it properly where it is.
His hemodynamics pressure and is okay?
You can see it on the screen. It's doing great. LA pressure is quite high, 60.
Okay.
So you like where I am, right? In the BICOM? Now it's LVOT.
Yeah, let me, this little bit of BICOM actually. Now it's LVOT.
Yeah.
Yeah, there you go.
Come back to 3D and force, Chandra sir. I just
Okay.
want to start it again properly.
Yeah, I think most important thing is taking your time and
Yeah.
Doing it is very important.
Let's take our time, make sure that I have a good perch in 3D and force. And then hold it there and then move it up and down.
See, it has rotated. See, it is
See
rotated.
That is why I was struggling.
Yeah, you're rotated quite a bit now. See that? And also you should come little lateral side.
Yeah, I was going to say that. Yeah, I think
Push it forward a little, right?
Yes.
What about now? Little more?
little more lateral.
Little more lateral? That is, push it in. Little more.
No, the more you push it in, it's going posterior. Maybe you should pull back.
No, you want to just come to BICOM and then me do the lateral. And me yeah, sorry, Ramesh.
Or let go of the M a little bit.
Yeah. That's
yeah, go on BICOM a little.
okay.
Otherwise, I'll just come back out and go back in, guys.
Yes.
That's what I'm leaning towards. I'm always concerned when I don't see this movement
Same here.
translate.
Yeah, even me.
So,
And I didn't see the lateral translate.
see, your guide is, I think, okay, but your clip arm CDS is coming at an angle.
Yes,
so
exactly.
Pull back your whole system.
Yeah.
In the right side on the kind of.
So you want me to invert the clip arms and take it out?
Yeah, but first just pull back and see how it is, and
more to medially, right? Pulling everything back.
Yeah, pulling everything back to just make sure that the CDS on the echo, you can see that it is bending a little bit.
Yeah, I know.
Angle. So once you get rid of that, maybe see how it is looking, and maybe letting go of some of the M that you put.
I did let go of some M. How is it now?
Getting better.
Still pull back on the CDS, I think, on the whole system. Pull back.
Okay.
Okay, that looks much better. So now look at an. Before inverting, I would make sure that now look at BICOM, proper BICOM.
Yeah.
And LVOT and 3D alpha. If it's not good, then invert and come
that's
out.
the plan. Chandra sir, shall we rotate one by one?
Yeah, just hold on. Here is BICOM here. So here you are closer, but you need to get it here. So you need to bring your system right here. Yeah.
More post. You want me to come more medial, lateral?
No, medial.
My whole perpendicularity is gone, Ramesh.
Yeah. You need to go a little bit more medial now here.
Ramesh,
Yeah.
I think my whole perpendicularity is gone in all these movements. Let me invert it, go into the
Yeah.
LA,
Yeah.
Right.
and then
Right.
let's get this done.
Absolutely.
Okay? Second time for luck. So I need to fluoro. Huh? Opening. Go to another view on the fluoro screen. I want to see if I'm inverting. Go to RAO, LAO.
On echo LVOT view will show you that
Yeah.
also, Dr. Chandra said.
Yeah.
I think you're inverted there.
Yeah, I think I am.
Yeah.
I'm slowly pulling out.
You're in the
Yeah,
LA.
you're back in the left atrium.
Yeah.
Good. Okay.
How you see that how anterior you are there?
So anterior, right?
Yeah.
I'm going to go back, close back again.
Yeah, I think when Dr. Chandra sir was talking about that's where he wanted you to be, I think that was a little bit more posterior and
Yeah.
you were a little anterior.
Okay.
I mean, obviously,
This
we
is
are
okay?
trying to grasp the reflex. Yeah.
Okay. So we start all over again, guys. Chandra sir, bicommissural.
Okay.
More medial. So I'll give some more M. And then I'll push it in a little. Chandra sir, can I see my clip arms?
No, don't push it yet, Sai. I think you have to pull back and
There you go.
let's go
Exactly.
to the proper intercommissural
there.
without a left atrial appendage view over there.
Chandra sir?
Yeah, no, I'm getting it there.
Yeah, there you go.
There you go.
Right.
Okay, that looks good. The view looks good. I can't see my clip.
So pull back your system a little bit
Yeah.
Already am.
and
I think
go
you might be
posterior
too
to the
high
guide.
above the. Yeah, you might be too high above the mitral valve plane.
Yeah.
Sai, you see that,
So
Sai?
go posterior on the guide and you'll come back.
I'm
into
just
it
doing
and
that.
you
One
see
second,
that in
guys.
intercommissural view.
One sec.
Yes.
Okay.
Yeah. Now we can see.
Check my trajectory.
It's going
You
to
can
go.
see it enough.
I think that trajectory is good, Sai.
I'm going a
On
little
the
towards the
intercommissural-
lateral, Ramesh, don't you think?
No, I think it's
See on the intercommissural view on the left side,
Yeah.
it looks good.
Good.
If you want, yeah, I think that's good. When you're going in, that's where you're going towards the.
flail area. I think it's
aspect.
yeah.
It's good.
You guys are
So
okay
your
with
clip arms are seen on fluoro. That means again we need to
Yeah,
orient.
go to NFOS and then,
Well.
yeah.
Just hold on.
So earlier, Dr. Srinivas Kumar was asking how to, why there's such a complex. Unfortunately, I agree with you, Dr. Kumar, that we need a much something simpler.
Sai,
But as of now,
clockwise rotation.
unfortunately,
I am.
we have
Clockwise, right?
only
see, look at that.
Microclip and Edwards,
yeah.
both of them. Pascal system, both of them
Just
are
push
still
inside, right?
not such a easy as TAVRs.
Ramesh,
But
have you had any
mitral valve
experience
itself
with
is
the
complex.
Pascal?
Sorry.
Have you had any experience with the Pascal, the Edwards device? That's a
No, it's
little
not.
simpler.
Yeah, a little bit simple. Not yet. We don't have it commercially approved in the United States.
Are you
yet.
okay with that?
Yeah, but little bit lateral it should come. Little.
Little pushing it forward.
That's good, Sai. Let's try that. A little bit counterclockwise.
Little counterclockwise.
You know what? I would give a little bit more counterclockwise. Because
Counterclockwise.
last time when we tried with that, it is. So even if it is little bit off of 12 and 6, more towards 12.0 or 05 or something like that.
Okay, so now you want me, now it's about 11:45 and 545. You want me to go more 12?
Yes.
Okay.
Okay.
I think that looks good.
It is
12.6.
little lateral,
Little more lateral.
Good, very good. Try that there. So,
Little anterior.
yeah, that's good. That's good, Sam. Keep it there. Let's see one second.
Yeah.
Just keep it there. I just want to see one thing.
Okay.
Yeah, I think the color shows that it is in the center. Very good. Okay. So I'll go to LVOT view, or by COM, I'll stay here.
Yep. I think I should go in now. Okay, guys?
Yeah.
That looks pretty good.
Yeah, I'm holding this dead steady.
I'll go in LVOT view usually,
Yeah.
but
Yep.
yeah. Okay.
Go to
No,
LVOT,
we- we-
sir.
Explain.
Yeah, that's what I was going to do.
Do you see the bend in the system as it's going down?
See, that is not going to help you with the same problem what we had.
So what do you suggest, Chandra, sir?
I think in order to avoid the bend, you have to pull the entire catheter delivery system a little bit back, guide. What do you think, Ramesh? I think we should
Go to AP.
Yeah.
pull back a little bit of the delivery system back. Keep it there and then just slowly pull it till it becomes perpendicular to the annular plane.
I'll leave the LA.
Right.
Stay right there, stay right there. So now posterior is in. Now if you're going to straighten out, anterior will fall in. Posterior is in. See, the perpendicularity is not seen there. Boy.
So on echo, we are looking at the right side of the screen, which is the LVOT view.
Yeah.
And
There. Now the
there,
anterior is in, posterior is
and-
not there.
Can I see a
I
3D
think, I think
enforced?
Sai, can I tell you something?
Ah,
It's not going to be perfect. I'm going to give the LVOT view,
ah.
and when I want you to try to rotate your system little bit counterclockwise or clockwise, so that both leaflets, both
Got it.
arms are seen
Yep.
when you're seeing this thing. So that's what I want you to do. So try and see. So I'm just keeping it there. You just gently, there you go. Rotate it till you see them perpendicular enough and long. There you go. So now that's perfect, because we really can't. And now both are in. If you can, just hold on. There you go.
Posterior's in.
the anterior is going in and out, right?
Yeah.
Yeah. That's exactly what's happening. I got the posterior in. Lung down. What do you think?
Now I think if there is a way that maybe you should go in a little bit. I think the anterior is not falling in.
So just hold it there. I'll just come into
Yeah.
your plane. Just hang on. Okay, there you go.
Yeah, now drop the dripper. Yeah, drop it now. Drop it quickly. Drop it.
Yeah, I've dropped it. I'm closing it
close
30
it.
degrees.
Close it quickly. Let's see.
Okay. Okay.
Both are in.
Shall I close the clip nicely?
Close it and let's see how it is. Because I think
Clip lightly.
it's an unorthodox view.
I'm locking it. I'm not yet gone to 60. Yeah, I've locked it.
I'm not sure you have the leaflets there, Sai.
Yeah.
Let me
and
just close it
echo-
and see. Is there any harm in closing it, guys? Let me just
No
close it.
harm in closing it.
No,
but,
no harm.
but you can put color and see and
Look at it now. Anterior's off, you think? I think both
well,
are there.
I think that for sure that it doesn't seem that
No,
you have
no. I think both
Both
are
are
in.
in.
But
Look at that.
both are
yeah,
in.
look like both are in.
Both
by
are in, but
mobility of
we'll need to verify. I think I won't I won't take it off. Just let's verify quickly.
Yeah, I'm just going to stop.
Yeah, because I think it is in.
Just going to release the tension a
because
little.
this guy has got a severe myxomatous leaflets also, and I think there's going to be problem. See, there your anterior is in. Okay, just hold on. Let me get the view.
Yeah, hang on. I'm just releasing the tension. I'm tightening everything. He made me work for it, huh? Saurabh?
Just hold on
Just,
there.
you know,
It's a hard case.
no. So what kept happening was the.
No, just hold it there, Sai, please. Just hold on.
Sorry, sorry.
Let me verify here. So
In
there.
the previous case,
yeah.
as he was tightening more, the MRs decreased significantly. Can you check like that?
Yeah, usually in
See,
the
left.
flow,
See, one thing has
when you
happened is my
tighten it
left
more.
atrial pressure has gone down from 60 down to 33 V wave. No, I'm fully closed. Yeah, I'm fully closed.
So both anterior and posterior leaflet are grabbed.
Can you see that? It looks like a good grab, huh?
You guys can see it, but see the prolapse that is occurring of the anterior leaflet, which was unmasked by the flail of the posterior leaflet. Now you're quite obviously you can see that. I think I'm going to take the color this thing off. Let me put the color here.
So let's put the color and see. I can't believe it took 10 minutes to get the puncture, and normally what the grasp takes, you know, this, I guess this is what Mitra clip is. The anatomies are so different.
So compared to before, is very little MR, but I'm going to show in the transgastric view. I just let's see here. Just hold on one second.
Saurabh,
But
Ramesh,
you haven't tightened it yet, right?
I haven't tightened it fully, Ramesh. No. Do you want me to? I've closed the clip lever.
Fully tighten it. Let's see. There's
Okay.
nothing wrong. You can
I
always
tighten
release
fully.
it.
Because the leaflets are so myxomatous, I don't want to just, you know.
I would tighten it, Sai, right now. Just
Yeah, you can put color.
yeah. See, compared to what it was, see, there's going to be some amount of MR because adjoining that other area, you're going to get it. But where we are seeing, I'm going to go through different views so that everybody
bad,
can
no?
see. So now I'm going to go
think
back
so.
to the commissural view.
Vijay, what do you think? We might have to put
Dr.
another
Chandra,
clip.
can you walk in and out of the leaflets just from one side to the other?
Yeah,
moving the cursor?
here. So now, anterior commissure coming back, coming up. There the clip is. Now I'm going to
Yeah,
the
see, you can, both leaflets are
posterior.
in, Saurabh.
See
I
now,
think they're in. The question is how much of them are in. I
Yeah.
can't tell yet.
Neither can I.
what was
The
the question?
posterior is in well, that I can tell.
No, what was the question? I didn't.
How
hear.
much of the leaflets are in? Would you want to go for a bicom and then check, Chandra?
Yeah, that's what I'm going to do right now, slowly.
Okay. Saurabh, Ramesh, do you agree with that?
Yeah, we agree with doing a
I
leaflet
agree with
insertion
Saurabh.
assessment.
Let's check but if the leaflet insertion is really good and the MR reduction is more than 2+, I would accept this. in
No,
this
here,
patient.
see,
Hey, guys, look at that. Look at that.
Here it is fine, but there is still the posterior leaflet is a large leaflet P2 and it is flail. So I think my feeling is that we may have to see in this view is nothing there. Okay, I'm just going to go through.
There's no MR, huh?
Not
Yeah,
in this view,
not
but
in
I
this
think
view.
we're going to go as Srinivas asked. I'm going to go a little bit posterior. See that there is that still the flail is still there, part of that flail which is still there. So you are able to reduce one aspect of the flail segment. Now the other aspect is still there. Maybe adjoining that we may have to put another one.
Okay.
See, but it is very mild. I won't take off that clip. I'll leave the clip and put another one right here.
That's fine, Chandra sir. But before this, can we just quickly look at the bicom? Look at how it is.
I am going to. I'll show you here. So here. Okay. Now I'm going to go through the views.
Saurabh, what do you think?
This is looking much more reassuring
Yep.
Yeah, look
I
at
thought
because the mobility of the leaflet has decreased. And
Drastically.
I generally like to go from a span over from one side of the clip to the other, and then just measure how much leaflet you have. So, for example, even there, and then if you just walk into the clip slowly from both the medial side and the lateral side, you can measure and see if the leaflets are all the way down to the V.
You want to go from 0 degree or you want to go from which view you would like to? I'll do it for you. Tell me.
Just go back to the Bicom view and then put your cursor on one side, maybe start medial, and then just slowly walk into the clip.
Very good. Okay. So, Bicom view. Okay.
Oh, there is enough guidance,
So
right?
here.
You want to throw some color in there, Chandra sir?
No, okay. Then I think you want me to. Here is the.
So see here, it's quite reassuring when you look at the anterior leaflet on how the redundancy of that anterior leaflet is much better.
Yeah.
The mobility is improved. So the anterior to me is looking
good,
pretty decent.
Yeah.
Posterior, I haven't seen yet. I mean, it may be good. I just haven't seen enough to make up my mind.
No. Here I'm tilting it, going back to the lateral commissure slowly. So now I'm going back now. I'll bring the
there.
clip
You see
in.
the posterior?
Yeah. Then I'm going to go back. See, we still have the little bit of flail of the posterior segment is still present. But fair amount of the leaflet has been grabbed in. I think
I think this is looking pretty decent to
Yep.
me. It looks good. Ramesh, what do you think?
And mitral regurgitation also has decreased significantly, no?
Yeah, it
Yeah.
was 4.
Yeah.
Mild regurgitation, I think, would
yeah,
be less than
but
2.
look at here. See this? This is the part of the other part of the leaflet.
That's okay, but here I can go put another NTR in.
Exactly. Yeah.
But
That's
I just want to know now, everybody's happy with this clip?
yes.
Both the leaflet insertion is good. Can we do one final check?
Okay.
And the MR reduction is good. From 60, my LAV is down to 30. Guys, while Professor Chandra is checking, Ramesh, Saurabh, the panelists, I look at this view. I think I'm very reassured with how much of my AML is in. I'm very reassured with how much of the PML is in. I think this clip is sitting nicely. It's a heavily myxomatous valve. There was a lot of loose caudate tissue floating around.
See, the issue here is, this is the 4-chamber view, and I'm extremely retroflexed. So I'm going to just advance. As I advance, you see the posterior leaflet and posterior commissure is coming.
No problem, Chandra sir. I'm just going to decide whether I'm going to leave this clip, and then we can do the other clip after that. Is that okay?
Yeah.
Are you okay with this clip?
Yeah, I'm fine with this clip.
You're happy with the insertion?
Yep.
You're happy with the grasp? You're happy with the MR reduction?
I think this clip is fine.
Okay.
Ramesh, what do you think?
I agree, Dr. Chandra sir. This is great grasp and a great MR reduction. So this clip I would leave it
Exactly.
And see what happens to the MR and decide.
So what I want to point out here is actually see.
Okay.
I think I agree with that. I just release this
Yeah.
one and then decide on whether you need a second one.
Absolutely. Chandra sir, can we?
Yeah, you can release it. Yeah.
I'm fully tight. Okay, now I'm fully tight. Okay, shall we do the final arm angle? LA pressures come down even more when I fully tighten. Okay, let's do the final arm angle. Okay, both arms are down. Okay. I'm opening back to neutral, right? Yeah. Half a turn to the close. One turn to open. Can I go to RAO, Andrew? I just want to see the clip arms. Some more. Okay, some more. I want to see the clip arms open up. Otherwise, go to LAO. Just go to LAO. Quickly, Andrew. Okay, come. Move the screen out of the way. Okay. Yeah. Close position neutral. Yep. Can we increase the flush rate?
See, the flail is still left.
This is the gripper. Okay. It's turned upside down, sorry. We go. Reduce the pressure a little. Not too much? That's good. Ramesh, Sarab, did I lose you?
No,
No,
I'm here.
it's still looking good.
Okay.
We're just impressed with your skill in getting this. This wasn't easy.
You know what? I don't know. I'm just going to floss this a little. I'm going to. This was bouncing all over the place. Huh? Oh, I have a lot of tissue in, guys. Now I'm going to open the white one, the lock lever cap. Anytime I use any terminology that's not in the IFU, Vinod reminds me. Okay. So when I say lock lever test, he says arm angle test. Okay. Maybe just to rile him up, I'm going to say I'm going to now pull on the white thingies. Okay. Are we good? So I'm taking the white one out. It's really tight here. Huh?
Yeah, this is one place where we have to make sure there's no knot inside.
Yeah, I am.
It has happened.
Ramesh, that's the last. You know, you won't believe how happy I am to see pink. So going to the second final lock lever, that's just for riling up Vinod. Vinod, half degree to the close. Bring it back to neutral. Half degree to the close. One full circle to the open till I feel resistance. Nothing is opening. Go back to neutral. Okay. All right. Grenade pin out. Grenade.
Sounds good.
Grenade pin out. Everything looks good. Professor Chandra, you'll just keep it there. Look at the clip. The MR also looks like hardly anything, right?
Well, in this view, yes.
Arm positioner. Okay. 9th, 1, 2, 3, 4, 5. Fluoride I don't need. 6, 7, 8, 9, and pull it out.
Dr. YVC, what do you think? Is looking good, right?
YVC, they're asking what do you think. Sorry, he doesn't. Hang on.
Yeah.
Okay. Pull this back.
One clip might be enough. Most likely we might not be needing the second one.
You're muted, Ramesh.
Yeah, very good.
Okay. Is the clip still stable, Chandra sir?
Yeah, it is.
Okay, good. Okay. So are we ready to release? Okay.
So, we've been pulling the gripper line now even before the clip separation. Ramesh, have you been doing that too?
No, with the G4, the gripper line is much easier, right, Saurabh?
Yeah, much easier, definitely.
So this gripper line has got so much tissue, it's stuck. I just have to wait for it to. Is that too close for comfort?
I would check and make sure there's not a knot.
No, this is the gripper line. There's no knot.
No knot, and it just, I think, will take some time. With each heartbeat, it'll come back.
Yeah.
But I think this is a great case and a great demonstration. And Dr. Srinivas Kumar, isn't this the first live case?
Yeah, I think done by Indian colleague Dr. Sai. Congratulations, and we could learn more because of the problems.
Thank you so much, guys. I think it's getting late. I'll pull this gripper line out slowly. I'm jittery about just yanking it out.
Till what stage is it again repositionable, Ramesh?
No, it's not repositionable, Srinivas.
Yeah, I'm just asking till what
We
level.
are done, Srini. We are done.
Okay, no problem.
So I can't
see. Up until
I think MR has regressed
Chandra,
significantly.
It's stable, right?
Yeah.
Yeah. So Srinivas, the steps in this are that you release he tested the lock, and then you release the lock line. And once you pull the lock line, then you can't really unlock the clip anymore, percutaneously. So at that point, it just becomes irretrievable. So up to that point, you could take it out.
I have so much tissue that it just won't come off. I think I'll pull the arm a little back. Is that better?
It's going to take a little longer. So sometimes it is really tough. Sometimes you're very lucky that the gripper line will come back easily. Take your own time. This is the time that you don't want to really do fast, because the spear can damage the reflex.
That's what I'm doing, but I'm really slow. It's taking unusually long. Anyway, guys, it's coming out like in millimeters. If you guys want to go off air, I completely understand.
Okay. Thank you, Sai. It's exactly 10 p.m. I think you showed excellently, and we could learn a lot of things because all of us are learning in this. We are not as comfortable as with TAVI because it's just approved. And
thank you all so
started
much.
Doing there, and hope to start in Apollo Health City also with you and Ramesh.
Thank you so much. I can't wait to start. Thank you all for having us from Team Chennai.
Until now, I think 1,000+ people were watching you.
Thank you so much.
Even this late. Thank you very much, and thank you YVC, and thank you Chandra sir.
Thank you,
Vijay
welcome.
Kumar.
Yeah.
You proved we can work beyond the boundaries of hospitals also. Congratulations.
Thank you so much.
Thank you.
Really great case. Well done.
Thank you so much, Saurabh. I was thinking it's going to be tough because the patient was unstable, but it's a lot tougher than it was. Thank you all so much.
Thank you.
Chandra sir, Ganesh, and Dampati, and YVC and Sai. Thank you.
Thank you. Bye-bye.
Thank you, Ramesh. Bye-bye. Thank you.
Namaste. I am Dr. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings to you best wishes from Fax Foundation, TCT India, South Asia 2021. As a part of our live case learning series, we bring to you some interesting live case learnings of another newer modality of therapy of management of severe mitral regurgitation percutaneously by using Mitra clip in a surgically unfit young patient who got hospitalized with recurrent hospitalizations. This was done as a desperate measure to give new lease of life to this young patient who could otherwise go into cardiac transplant only. This was shown by Dr.SaiSathish along with Dr.YVC Reddy and Dr. Vijay Kumar in Apollo Hospitals, Chennai. What we have learned in this case is how to assess and prepare these patients who are very sick, and how to initially stabilize them with some medical management and decongestive therapy, and then when to optimally take these patients up for the mitral clip procedure. And we all learned that the mitral regurgitation has to be severe and preferably with little roomy LAs for us to adjust the clips in the position. And also this patient has a very severe LV dysfunction, 15-20% of EF, where surgery was not possible, and surgeons felt that surgical repair or replacement could not be done because of a severely sick patient with very high LA pressures and PA pressures. That's how, as a palliative life-saving measure, this patient was planned after explaining in heart team concept, planned for mitral clip procedure. What we've learned is when you're doing such cases, we have to be very precise and do what is optimal to these patients, and then proper planning is required. And such patients will benefit only if MR is very severe, and assessment of MR, whether it is physiological or degenerative or any significant prolapse of leaflets, all that morphology assessment along with the severity of MR is equally important. And we have learned all that how to assess that both by transesophageal echo and the 3D echo pictures. So 3D echo also shows significantly the degenerated valve leaflet positions and probably some of the position leaflets which were prolapsing. All that could be effectively seen on 3D echo technology, provided we all become comfortable. The echo guidance is very important, and without proper echo expertise, probably we cannot develop this expertise in mitral clip procedure. This fact was very well highlighted by Dr.SaiSathish and also by Dr. Ramesh Dagupati, who was moderating the case on the other side. Then the patient's LV function was severely deranged, was also shown. LA pressures were significantly high, and monitoring was done to this patient. And then initially, how to do this transeptal puncture will be different compared to routine transeptals which we are doing in PBMV. Is you take the help of again transitional echo guidance and probably assessing it in the both short axis and long axis views. We tend to do puncture in a slightly posterior location, where we need to have a minimum distance of about 4 centimeters from the mitral annulus, so that later on the taking of the guide catheter inside and then the directing of the mitral clip would be relatively easier for during the assessment. This aspect of transeptal puncture technique using a jelly sheath and other was shown very clearly. Later, once the mitral clip was taken inside, how we need to direct the entire equipment and seeing the line of alignment, how to go into the mitral valve and how to avoid the chordae, all those were all done elegantly by Dr. Sai under the echo guidance of Dr. Chandra. So we also were fortunate to have Dr. Chandrasekhar, who was trained in Mayo Clinic, presently in Apollo Chennai, who is a great help in showing delivering the therapy for the mitral clip, because the proper assessment of the MR and then whether the clip went in normally without chordae, and then whether the clip has caught both the leaflets, anterior and posterior, all that aspects were very clearly shown. And once we got the clip free from a chordae and catching of both of the anterior and posterior leaflets, as we keep on tightening of the mitral clip, the MRs regress significantly, and this aspect was also demonstrated very well. And then we also have, if you have LA pressure monitoring, the LA pressures also significantly come down once the MR decreases after the mitral clip was also elegantly shown. After the deployment of single clip, because of time constraints, we couldn't see the second clip placement, but another clip was used, and finally MR was only traced at the end, as shown in the pictures which are sent again in the follow-up. So that's how I think we are able to treat the sicker patients using the mitral clip therapy, and we should be all thankful to technology and expertise for delivering such care to sick and needy patients of severe mitral regurgitation. We wish this technology becomes more popular. All of us learn from these such live cases and will be able to offer this therapy to more and more patients. We thank Dr.SaiSathish and Dr. Ramesh Dagupati for helping us in organization of this live case and excellent demonstration showing of this live case. Hope all of you have enjoyed this and learned a lot of new things in this upcoming technology. Another important aspect was also discussed is different types of clips which are available. NT, which was a regular one, and XT, which has a little more longer length of clips, and then original one was 4 mm in width. Now the wider ones of 6 mm width have also come. Actually, the XT ones probably will be used more for degenerative and more of significant mitral regurgitations, unlike the NT ones. Sometimes you could use combination of 2 or 3 clips to finally decrease MR. So all of us should become more comfortable with the technologies coming up and become comfortable with the usage of TEE and 3D and how to do transeptal punctures, and because each step is important in saving lives of such sick patients. Thank you for your patient watching, and hope you all like this live case learnings of a mitral clip procedure. Yours, Dr. A. Srinivas Kumar. Thank you.